And Dr. Saurabh. Okay. Ma'am, is it ready? Or we can call the next one and then you can come? Second पे आपका ready है उधर? You can just check. चल रहा है आ गया
We'll try to be as quick as possible that we are running late. So request the speakers to stick to time and minimum questions which we take up.
Good morning, everyone. My presentation is our experience with a single-piece sutureless scleral fixation hydrophilic foldable IOL. So no financial disclosure, no conflict of interest. It often feels like a ultimate goal in cataract surgery is implanting an intraocular lens. However, as soon as the posterior capsule or the capsular circle is compromised, the uncompromised outcome of this simple yet skill-demanding surgery comes crashing down. Some patients come to us pre-existing condition that cannot accommodate with a routine PCR, like dislocated IOLs, dislocated nucleus, PCR. So and what option do we have? Either we can go for ACL or iris claw lens, anterior, posterior, or we can go for a SFIL. But we have done this option. We have tried the CMT Flex IOL. The specifications are, it's a hydrophilic 26% with the optic size of 6 mm. Overall size is 13.75 mm with a dioptric range is minus 15 diopter to 55 diopter. And it's a 10-degree angulation that this is helpful to us because it's not going to rub on the surface of the iris. My study was on 10 patients. It's a prospective study and we have done around 10 cases. So we have calculated the IOL power with the Barrett Universal 2 and kept same as PCIOL power. So this is one of my case. I'm showing you the video. All the steps I'm showing to you. So as you can see, this is very important. You have to make a tunnel on both the sides with parallel to each other. I generally prefer 3 and 9 o'clock positions. This is because the tunnel is very important because below that the T which will come out from the tunnel will going to rest over it and going to protect it, and the T haptics will not going to fall. So this is another important step, that is with the MVR23 will make a sclerotomy in both the sides from where the IOL will come out. So this is the T part and this is the optic part. The T is a very important part. So we should be ready with our forceps which we have designed, and we are injecting the lens in a foldable way and we are just holding the T part of it, it is coming out and then the other side is coming out. So you can see the T part, you have to check everything after that. You have to hydro it properly and you don't have to suture it because it's already, there's no leakage. So you have to cover the flap and no need for sutures. So this is another way we can go by injecting through a tunnel. So you can see we have zoomed it with a microscope you can see clearly how the T pops out. This the T part pops out and another T can be delivered either directly or through the holding through the optic haptic junction, then putting the forceps from this side and bringing the other haptic from the sclerotomy. This is called the handshake technique, in which what we have to do is we have to hold the optic haptic junction with the help of a dialer or with the help of a forceps, and with the help of another forceps which we have designed, we have to bring it out, and this you can see the another side, the T is popping out. So this is the handshake technique to deliver the other part of the T. So this was another case of mine with PCR and there was a iridodialysis. So we thought of putting the CMT IOL through the tunnel. So you can see we are putting the IOL and we're ready with our forceps and bringing it out from one side. So here the T pops out, but what happens is we saw the other T got stuck in the mouth of the sclerotomy. We just saw it and we bring it out. So now the surgery is completed, almost the lens is centered. So these are the forces which we have designed. They are completely different. Their dimensions, their measurements are completely different from the other SFL forces because they are going to hold it properly. So we have increased the length as well as we broadened the tooth this so that it grabs the this T part of it very good. And this is the curved force which we have made so that we can manipulate easily to hold the T part of the CMT flex IOL when it goes above the iris. So these three forces which we have designed and we are going to patent it also. So these are the cases which we have done. And the results which we have found out that 4 patients mild corneal edema, 1 patient with high microcystic edema, and 1 patient was having low intraocular pressure. So maximum vision which we have got was around 6.9 and also 1 patient got 6.6. So these are some of the pics which I am showing to you within a week and within 3 weeks. Almost the cornea was clear and the lens is centered. So discussion, it is easy to use, very well centered. T haptics are self-retaining, good for the cornea, can be done using a tunnel or by injecting, non-irritating for the patient. So I just contribute to the safe and easy to learn. Thank you. Some references and thank you.
Okay, ma'am. Have you ever noticed any sagging? Like, do you take white to white in this of patients?
No, we don't take white because it's a standard dimension 13.75 and they don't.
But all eyes are not same, na? So, have you ever like?
No, we have not taken.
And have you ever noticed the T getting broken because of the stretch?
In one case, the T was broken. I have observed that. Then we have changed. Just in one case. Then we thought we don't have to pull it. We just have to drag it slowly and slowly.
So that just was not mentioned in this, na?
It was just one case.
Okay. Thank you. Thank you. Dr. Asta, yeah, please start.
Good afternoon, respected panelists and delegates. I am going to present my paper titled Impact of Simulator-Based Learning on Cataract Surgery Training of Ophthalmology Postgraduates. I have no financial disclosures. So cataract surgery is one of the most commonly performed, technically demanding surgeries, and it requires consistent training. So we all know that simulation-based learning started with aviation, and now it has been increasingly integrated in medical education, and in recent years even in ophthalmology training it has been integrated. But there is little research on what trainees think, what is their perception and what is their expectation out of the simulator training. So if we see traditional training, it is training on patients, so it's a hands-on in live surgical settings it occurs, where patient safety is a concern because the naive or the neophyte surgeons, they are training directly on the patients, they are practically learning the surgery on patients. So there is limited opportunities for skill refinement. There's also the feedback that they get is from their mentors by and large. So it depends on who is training them, and also there is non-uniformity in training across centers. So if a resident is training in a high volume center, he gets more hands-on cases. If he's training in a center where the hands-on experience is less, his training would lack. When we compare this to a simulator-based training, here there is training that occurs in a safe and controlled environment. So it is an immersive experience. It is a machine that teaches you, and this environment is reproducible. So it is learner-centric. So if a student commits mistakes, it is in a safe environment. He gets the opportunity to repeat the step in that same environment and improve. So he can do it repetitively in a immersive and safe environment. He or she can practice intricate movements, he can acquire technical proficiency, and he also gets feedback based on data-driven metrics. So not only does he train in steps of the surgery, but also it helps to develop hand-eye coordination, depth perception, and also tremor control, which is very important for microsurgery like cataract surgery. And also, it helps to develop the surgical decision making and in building confidence. So learning is largely defined by goals, and what experience the learner has. So if the learner has a complication, his confidence really it is like a setback to him, and also it is harmful for the patients, and it also jeopardizes the trust that the patient has for the doctor. And it is also seen that when a student is prepared with the simulation, his surgical time also decreases in the OR when he's doing his case. So the virtual reality platform that we have at our center, it is from the IC Magic. So it has an OR machine interface, which is just like the what the surgeon will see in the OT. And then it has 2-axis phaco pedal, and it is validated. And evaluation can be done by the trainer also online. So it helps to develop basic microsurgical skills, steps of cataract surgery, and also advanced modules are present, like how to do surgery in floppy iris, weakened zonules, PCR, how to put a CTR, iris expansion ring. So it has, the trainee can progress through all these steps. So our aim was to analyze the overall experience, benefits and challenges of simulated training on cataract surgery of postgraduate residents at 2 tertiary eye care hospitals in North India. So we took the postgraduate students who were undergoing this training on the ICVR Magic at 2 government hospitals. So we distributed an online semi-structured questionnaire which had 26 closed-end questions, and the questions had a neutral tone, and they were asked in some questions to grade their experience on Likert scale. So 54% respondents were in the PG year 2, 61.9% were females, and majority of the residents were in the 25 to 30 age group. They had, before simulated, they had done less than 10 surgeries in the OR, and they were getting approximately 1 to 3 hours of training per month on the simulator. And 73% of residents found it to be inadequate. And the main barrier was that they were busy, the training was happening in the busy clinical work, so they could not get sufficient time to practice. Capsulorhexis and nucleus sculpting and chopping were the most common steps, and they found maximum benefit in improving capsulorhexis skills, whereas nucleus chopping was difficult for them. It additionally, 66% said that it benefited their hand-eye coordination, depth perception, and hand tremors and instrument handling. And approximately most of the responses were like it helped them moderately. So we did not get very marked improvement or no improvement in these. And very interestingly, 92.9% said that it improves their confidence and anxiety. And 78.6% students felt that actual surgery and simulation surgery that they were doing were quite close. And 76% said it helped in reductions in complications. And when they were asked, if compared to goat's eye training, 54% said that they improved, and they would recommend it to their juniors. So this is just the small video, and I'll skip through this.
Kindly wind up, please.
Yeah. And so the conclusions of our study was that most residents found simulated training useful for surgical skill development and for building their confidence in a safe environment. It's a promising teaching methods which will eventually benefit the patients, and it mandates surgical simulation to be inbuilt in residency training program. And the study confirms the feasibility and positive impact of simulator surgical training, the only limitation being the high cost of the simulator. Thank you. These are my references.
Thank you so much. A nice talk, and this is probably the need of the hour, and it is for patient benefit. Of course, the cost is the factor, as you said. Thank you so much. Can we have the next speaker, please? Dr. Vandana Srinath. Clinical features and management of late IOL decentration in the dead bag syndrome. Can the next speaker check if she's ready?
Good afternoon. Clinical features and management of late IOL decentration in the dead bag syndrome. No financial disclosure. This was a term coined by Dr. Samuel Masket, which characterized by spontaneous rupture of the posterior capsule years after an uneventful IOL cataract surgery. IOL decentration within or outside the bag remains in situ with total or partial anchorage, and it has always a clear capsular bag without fibrotic changes. Many authors have described the clinical and histopathological findings in the dead bag syndrome. This is a distinct clinical entity which is to be differentiated from zonulopathy, where the whole bag with the IOL decenters due to weak zonules. In the dead bag syndrome, the bag remains in situ and there is a spontaneous posterior capsule rupture, only the IOL decenters or dislocates. The aim of this study was to study the clinical features and management of eyes with dead bag syndrome. This was a prospective interventional case series of eyes that presented with late decentration of IOL with a ruptured or absent posterior capsule after an uneventful cataract surgery from June 21 to October 24. After the thorough history and an evaluation, the presence of the IOL, the position of the IOL, the presence of a posterior capsule split or a rupture, the OCT imaging techniques, UBM and photo documentation was done. And the classical feature that we found in all cases was that there was a posterior capsule rupture which presented to us in these ways with either an IOL decentration within the bag, outside the bag, or totally onto the retina, into the vitreous. And it was always a clear, relatively intact capsular bag. You can see the intact capsular excess margin, only there's a posterior capsule split with a clear posterior capsule, and the IOL decentered. 46 eyes underwent surgery for IOL exchange in all these cases. 30 eyes had in the bag IOL and 16 eyes had a total dislocation into the vitreous cavity. What was predominant was that 91% of these were males, and this was statistically significant. 58% eyes had entire or part of the IOL inside the bag, and 30% had total dislocation. The age at presentation, 76% eyes presented between 61 to 80 years of age. The time after the cataract surgery, 75% presented between 11 to 20 years of age. 36 patients had unilateral, 7 patients had bilateral, which was shown for the first time. More than 50% eyes had axial myopia, 87% eyes had an improvement in the total visual acuity. The dead bag syndrome, the axial length, more than 53% had more than 24 millimeters of axial length. That means they were myopic. The type of IOL in the primary cataract surgery, 71% eyes had the single-piece hydrophobic IOL, with the least number in the 3-piece and hydrophilic and the PMMA. And this, the test of multiple proportions showed a significantly higher number of the single-piece hydrophobic acrylic lens. This was statistically very highly significant. And the duration between comparing the IOL exchange was not statistically significant. The IOL explantation after decentered was done after a detailed preoperative examination, and we used the 3-port pars plana vitrectomy by a retinal colleague. And we used the Yamani technique of intrascleral haptic fixation of a 3-piece foldable lens. The postoperative outcomes were visually acceptable. We had certain complications like the early IOP spike, which was medically managed, cystoid macular edema, which was medically treated. Only one person needed Ozurdex because of a persistent cystoid macular edema. The epiretinal membranes were not very significant and were left alone, and we had optic capture to pupil in 2 eyes, and a retinal detachment which was detected on table and treated at the same time as the secondary IOL. So in conclusion, the risk factors were male predominance, myopia, duration of PCR from the primary cataract surgery. It's a bilateral disease, could have a genetic predisposition, which needs further research, and clinical implications are that patients must remain in lifelong follow-up. And we have an ongoing research on histopathology, which shows paucity of the lens epithelial cells to be the major contributor for the dead bag syndrome. And we are doing genetic studies where we have found gene variants which have been identified which could predispose to posterior capsule fragility. Thank you.
Thank you so much, ma'am.
What percentage of cases would you say was there in your series? I mean, how much was the percentage of dead bag syndrome?
We could say about 0.1%.
Right.
Totally. But since we are a tertiary eye care center, we have implanted, since the early 2000s, we have been implanting the hydrophobic single-piece Acrysoft lenses.
Right.
But it's only recently now, since we are 11 to 20 years down the line, we are seeing a lot of the dead bag syndromes.
Right.
It is increasing in frequency.
Sure. Thank you so much.
Thank you.
So the next speaker is Dr. Ravi.
Yes. Good afternoon, everyone. My topic is clinical outcomes of toric and monofocal intraocular lens implantation on myopia is target refraction. Coming to the background of my study, a number of advances in cataract surgical techniques have happened in the recent times to improve the quality of postoperative visual acuity. However, corneal astigmatism reduces the uncorrected visual acuity after surgery, and which is one of the most important reasons for increased dependence on corrective lenses. Although a number of techniques are available to correct this corneal astigmatism, toric IOL implantation along with LRA are the most commonly employed techniques, and toric IOL implantation has been reported to be more effective when compared to LRA and is the most recommended method for correcting astigmatism in cataract patients. But there is an interesting situation arises when the target refraction is not emmetropia, but it is myopia like -2 diopters. In such situations, usually surgeons do not opt for toric IOLs because the patients should always wear the spectacles for distant vision correction, for driving, walking, etc. So the astigmatism can also be corrected with that spectacles. However, such patients do not always wear these glasses at home, and they can often take it off when taking a shower or reading a book. In such situations, the uncorrected visual acuity becomes more important. With this background, I go to the purpose of my study to compare the clinical outcomes of toric IOL and monofocal IOL implantation in patients when the target refraction is -2 diopters and with corneal astigmatism more than 1.5 diopters. Methods, it's a retrospective study done over a period of 3 years. All the patients, as I have mentioned, with age-related cataract with corneal astigmatism more than 1.5 diopters and target refraction of -2 diopters have been included. We excluded all the patients with history of any ocular disease affecting the visual acuity, any history of retinal diseases, or an eye with irregular astigmatism like keratoconus or keratectasia. Preoperatively, we have evaluated detailed medical history, slit lamp examination, fundus examination, and distant uncorrected visual acuity and best corrected visual acuity. And implantation of the lens and the choice of the IOL was given to the patient after explaining the cause. All the surgeries were performed by a single surgeon under topical anesthesia, and the lenses implanted were of Johnson & Johnson Technics series lens. And postoperatively on day 1, first week, first month and second month, we measured the distant and near uncorrected and best corrected visual acuity, autorefraction, keratometry and slit lamp examinations. And in toric IOL group, pupils were dilated and see the any rotation 2 months postoperatively. Coming to the results, 40 patients in each group were included. As expected, the uncorrected visual acuity at a distance improved in both the groups, but this improvement, as we can see, was statistically more significant in case of toric IOL group when compared to that of the monofocal group. However, in best corrected visual acuity, there was no statistical difference between the two groups. And coming to the uncorrected visual acuity at near, it was statistically more significant in the toric IOL group when compared to monofocal group. When compared to the spherical equivalent and corneal astigmatism, there was no statistical significant difference between the two groups. However, in case of residual keratometric cylinder, that is the corneal cylinder, there was statistically significant, and it was much lower in the toric IOL group. There were no intraoperative or postoperative complications during our study, and no requirement for any extra procedures were required. The same thing expected here. Coming to the review of literature, a number of studies over a period of time have highlighted the importance of astigmatism as a hindrance to the quality of vision postoperatively. And a study by name Singh et al. Has reported uncorrected myopic astigmatism of more than 1 diopter results in a large loss of distant visual acuity without additional improvement in case of near visual acuity, and uncorrected hyperopic astigmatism results in deterioration of both distance and near visual acuity. The current study showed significant differences between the monofocal and toric IOL group, particularly the uncorrected visual acuity in the toric IOL group was significantly better at 2 months postoperatively. Uncorrected visual acuity can be quite important considering that times without spectacle usage for patients at home may be long. And myopia prevalence at the same time is increasing worldwide. Considering educational activities, continuous urbanization and westernization, it is estimated that the number of patients with myopia seeking cataract surgery will increase in the future. And the consultation on toric IOL with myopic target refraction is likely to increase in such patients. So based on the results of our study, we recommend toric IOL implantation in such patients to offer better quality of life after cataract surgery. The limitations of our study included retrospective study design, short duration of follow-up like 2 months, and we did not measure the subjective satisfaction after surgery in both groups. Coming to the conclusions, when myopic refraction such as -2 diopter was the target power with corneal astigmatism, toric IOL implantation led to excellent improvement in both near and distant visual uncorrected visual acuity. Implantation of toric IOL was superior to monofocal IOL group in terms of uncorrected visual acuity in both near and distance. This may be helpful when ophthalmologists consult sick patients And this could be an evidence in clinical practice to more actively recommend toric IOL when performing cataract surgery in patients with myopia. These are my references. Thank you.
So, I just wanted to ask why, like today, nowadays, cataract is called a refractive surgery. Why you have taken myopia as a target refraction?
So patients who are having high myopia, where the overcorrection or more of overcorrection leading to hypermetropic correction may lead to the more problematic for the patient. Such patients will vote for myopic as target refractions.
No, but in myopia also we can keep it as a target emetropia, and other eye we can do monovision kind of a thing.
So we have taken only one eye in this study, sir. We couldn't take the other eye.
Okay, thank you.
Thank you.
So the next speaker, Dr. Bidisha, Dr. Shivani. I request the next speaker to be ready with the presentation, no, so that it's easier.
Cataract being a refractive surgery now, so probably target myopia is probably not recommended these days. It should be probably emetropia. Of course, you don't have to err on the hypermetropia side. You have to do the measurements, the biometry, maybe on another machine, and just be sure that it be emetropia, and maybe as Dr. Vipul said, a little monovision might be preferred. A target refraction of -2 might be a little too much, and patient might not be very happy. Yeah, please start with the next. Yeah, please start.
Good afternoon, everyone. The topic of my presentation is multifocal IOL, many focuses, one surface, trifocal, three focuses, three surfaces. Choose your clarity. There is no financial disclosure. So high definition analyzer, it is an instrument which is based on the double pass technique, which is developed by Visumetrics. The components measured by HD analyzer are objective scattering index, tear film stability, depth of focus, and best focus. The comparison between multifocal and trifocal IOLs will help in assessing the quality and the quantity of vision in the correction of high refractive errors. So this OSI will be useful in comparing the visual outcomes and the diffraction of light in multifocal versus trifocal IOLs. The objective of our study was to compare the optical quality between multifocal and trifocal IOLs, to evaluate the stability, efficacy, and safety, analyze the light diffraction patterns, and to determine superior clinical optical performance. So the study was a prospective study, interventional, non-randomized study carried in a tertiary eye care center in Bangalore for a duration of 2 years. 200 eyes were selected, out of which 100 eyes were selected in each group of multifocal and trifocal, with age more than 45 years, undergoing cataract surgery with healthy ocular surface, with Technics multifocal IOL, Zeiss at LISA 809M model IOL in multifocal group, and Optiflex Trio, Acris of IQ Panoptics, Rayner trifocal, Technis Synergy IOL, Zeiss at LISA 839MP model IOL in trifocal IOL group were selected. The examination included slit lamp biomicroscopy, dilated fundus examination, measurement of uncorrected distance visual acuity and near visual acuity, and objective scattering index, which was done on post-operative day 1 and day 30 in these patients. So the demographic details were comparable in both the groups. When we compare the visual outcomes between trifocal and multifocal group as a whole, the visual acuity were comparable in both the groups, but the OSI was found to be lesser in cases of multifocal IOL than trifocal IOL. But when we compared the individual IOLs in each group, so we found that Zeiss multifocal IOL had lesser OSI as compared to Technics multifocal IOL in cases of multifocal group. In case of trifocal IOL, we found Zeiss at Lisa trifocal IOL had lesser OSI as compared to other IOLs in the trifocal group. So the key parameters which influence the OSI are the pupil diameter, apodization, number of diffractive rings, central clear zone diameter, near addition, light utilization and distribution. So there are many studies which compared OSI in different types of IOL, but in our study we compared OSI in between multifocal and trifocal IOL, which offers important information on their optical characteristics and potential clinical applications. So in our study, multifocal IOLs have outperformed the trifocal IOL in terms of optical quality. Except intermediate visual acuity, which is better in trifocal IOLs, distance and near visual acuity measurements were comparable in both the groups. The important considerations to be taken in this comparison were the post-op day 1 versus day 30 differences due to the impact of corneal edema, influence of anterior chamber reaction, role of spherical aberration and light distribution patterns. So we concluded that the superior optical performance of Zeiss intraocular lenses in both the groups, it is due to the neutral spherical aberration and optimal light distribution. So the clinical applications that can be used is the patient selection criteria and the expected visual outcomes can be assessed to manage patient expectations and for proper post-op care considerations. So we conclude that though multifocal and trifocal IOLs have comparable distance and near visual acuity, with intermediate visual acuity being better in trifocal IOL, but OSI clearly states that multifocal is better than trifocal IOL. So IOL designs come in a variety of forms today, each with unique advantages and restrictions. In patients with ocular comorbidities like retinal comorbidities, etc., IOLs which induce lesser scattering index will have better clinical resolution in these patients. Though OSI is mainly an optical phenomena and vision a neural phenomena, so correlating both of these factors will give a better visual outcome. So further more research opportunities that could have been done in this study was long-term follow-up of these patients, the quality of life assessments, impact of different optical designs, role of new measurement technologies, and patient satisfaction correlation should have been considered, which was not taken into account in our study. These are my references. Thank you.
So I wanted to ask, like at the start of the study you told you have taken multiple lenses, but
Yes,
in comparison you have just compared 2 lenses. So why at the start of the study you took, like you told in the study there are many
So actually
lenses.
we did not take into consideration on the number of individual lenses. We just randomly selected 100 IOLs in those 2 years
But
period
you
in our
compared
institute.
only the 2, right?
No sir, as a group we have compared all the multifocal and trifocal IOL of those 100 patients. In that 100 patients, the individual lenses also we have compared which were used in our institute.
And in one of the slide you told multifocals are better in optical quality than trifocals.
Yes
But
sir.
nowadays it's the reverse that we are
Yeah.
using, right?
Yeah.
How will you explain that then?
So because we have compared only one parameter, that is the OSI just, but we didn't compare the other parameters like the patient satisfaction rate and
So how
contrast
will
and
this
aberrations.
study help us? In what regard do you think will it help?
This study will help in making us understand that not only OSI but also other parameters are to be considered depending on the patient requirements.
Okay, thank you.
Thank you.
How frequently do you do multifocals vis-a-vis trifocals in your center?
Sir, like in our center for private patients, like
Like-
mostly multifocal and trifocal have been used
So,
depending on their requirements because
So
most
like
of them,
out of 100 patients, roughly how many multifocals and how many trifocals?
out of 100, around 10 will be multifocal and 10 will be trifocal, sir.
Right. Almost equal numbers
Yes,
of
sir.
multifocals and trifocals.
Yes, sir.
Right. Thank you.
Thank you, sir.
So you can start now.
A very good afternoon, one and all. I'm going to present a prospective study on safety of routine hydrodissection in posterior polar cataract with intact PC, imaged using anterior segment OCT. Avoiding hydrodissection in polar cataracts causes difficulty in rotating the nucleus, which is difficult to chop, and also we are left with a dense epinuclear sheet. All these leads to increase in surgical time and manipulation, which again increases the risk of PC dehiscence. And we know that there is a strong scientific literature evidence of anterior segment OCT in the preoperative evaluation of posterior capsule in polar cataracts, and it has a high negative predictive value, which means if the PC is traced intact in the preoperatively, it is unlikely to rupture during cataract surgery. And Titial et al. Has demonstrated the safety of hydrodissection in type 1 PPC imaged using intraoperative OCT, and out of the 19 eyes where the PC was distinct, with hydrodissection, he reported an incidence of PCR to be 0. And they also mentioned that the preoperative AIOS-OCT images correlated with the intraoperative OCT image. We know that the talk of hydrodissection in PPC is controversial, but keeping in mind of these two scientific evidence, we designed a study to evaluate the safety of routine hydrodissection in polar cataracts with intact posterior capsule imaged using Swepso's anterior segment OCT. It was a prospective interventional study. Ethics committee approval was obtained, 8 months period, and it was done at Eye Foundation, Coimbatore. Eyes with typical PPC, we did a slit lamp imaging and also did the AIOS-OCT. And in eyes where the posterior capsule could be traced intact beyond the polar opacity were grouped with intact PC, and we did a gentle hydrodissection and nuclear rotation. And in eyes where the posterior capsule was not clearly delineated beyond the polar opacity were grouped as PC with discontinuous PC, and we did hydro delineation and the nucleus was not rotated. Group 3 PPC was very uncommon, where the PC was open with outpouching of the lens matter in the patella fossa. We had only one eye and we excluded this from our study. In eyes where, in group 1 eyes, after making a clear corneal incision and a rhexis of adequate size of 5 mm, we did gentle hydrodissection using a 27 gauge cannula. The balanced salt solution is injected gently but slowly, and we observe the fluid wave to pass across the polar opacity, and once this is done, we gently decompress the nucleus and rotate it. The nucleotomy technique varied between direct chop and stop and chop. Routine phacoemulsification parameters were used. As cataract surgeons, we are always used to rotate the nucleus and keep the nucleus in the opposite quadrant of opposite side of the clear corneal incision for better chopping. And doing a gentle hydrodissection and nuclear rotation helps us to manage the nucleus more efficiently and safely. And also you can see that at the end of phacoemulsification, the epinucleus comes along with the nucleus, and there is no need to deal the dense epinucleus plate. All we have to do is remove the cortex and place the IOL of choice. In cases in the flax, we did not increase the posterior offset, and we did very gentle hydrodissection, keeping in mind the nemodissection that would have already happened. In group 2 PPC, after hydrodissection, only hydro delineation was done, and after golden ring, we removed the epinucleus and lifted the endonucleus and emulsified it, and the epinucleus plate was visco-dissected and then removed, and the IOL was placed. In the flax group, we increased the posterior offset to 800 microns. So the outcome measure was to just assess the PCR rate in the two groups. Most commonly seen posterior polar cataract is type 1 with 54 eyes and 76%, and we had 1 eye of PCR in group 1 whereas 4 in group 2, and this was statistically significant. When we analyzed the video and the AIOS-OCT of this rent patient in group 1, the AIOS-OCT PC was intact, but this was one of the first case of the surgeons, and the hydro was little forceful, and it resulted in a capsule blowout after hydrodissection. So hence care should be taken to avoid hydrodissection, and all other precautions of maintaining the AC, everything has to be followed. The negative predictive value of the SS-based anterior segment OCT with gentle hydrodissection is 98.1%, and the positive predictive value of 25%, which means that if the PC is discontinuous, not all, it implies that it is dehiscent. It could be because of the dense polar opacity, which has not let the scan to penetrate and visualize the posterior capsule. Few studies has been documented in the literature regarding the hydrodissection, and these studies, they have not done anterior segment OCT in the preoperative period. And one study by Asia et al., it was a retrospective study of 10 eyes where he has done flax and reported no PCR. And this was the study by Titial et al., which I have alluded to. And we have used AIOS-OCT to prick the low risk gradient, and we have performed a gentle hydrodissection. The strength of a study is a prospective study and its large sample size. And the limitation, we had very less eyes in the flax group, so we could not compare. And 5 experienced surgeons were involved, so there could be interpersonal surgeons variability. So to conclude, Gentle hydrodissection and nuclear rotation could be done in this low-risk variant of PPC guided by anterior segment OCT for efficient nucleus and epinucleus management. Care should be taken to avoid overzealous hydrodissection. Thank you.
So ma'am, do you think like if this study would have been by a single surgeon, would the outcome would have been different?
Actually, no. Actually, if you are going to take one single experienced surgeon, then we can attribute the success of the surgery to that experienced surgeon. Here we have 5 different surgeons, one with 30 to 40 years of experience, another with 20, another with 10.
So how will you compare the results then? Because if the experience of surgeon is different.
No, that's what. In the type 1 PPC, only one case had a PCR. That was the first case, and all other cases which was done, distributed all across, we didn't have any PC dehiscence in the type 1.
Other than that, have you noticed any PCR like happening after, like we are doing when we're closing the eye or when we put the
we
lens?
followed all other precautions like maintaining the anterior chamber, not polishing the posterior capsule, not overhydrating. All others were followed. Only variable which we deferred was only doing a gentle hydrodissection and nuclear rotation if the PC was intact in the pre-op imaging. All other precautions were followed. Yeah.
Thank you. Okay, thank you.
Thank you so much. A nice study.
Dr. Rishva, yeah, please.
Good afternoon, everyone. I'm Dr. Ishwa. I'll be discussing about the impact of virtual reality simulator-based training in reducing complications in cataract. So, manual small incision cataract surgery is widely used in developing countries as it is also cost effective as compared to phacoemulsification. But the main challenge will be training. So, the traditional training relies on direct patient surgery, increasing the risks, high complication rates amongst the novice surgeons, and limited access to experienced trainers in many regions. So there have been alternative training models like the animal or cadaverized inanimate objects and virtual reality simulator. So what is VRS and why VRS? So the VRS was initially used for aviation and now it is used in ophthalmology. It offers M6 training, phacoemulsification, suturing and complication management. It enhances the skill acquisition in a risk-free environment by providing repeated practice, realistic tactile feedback, and motion physics. So the objective of the study was to assess the impact of VRS training on M6 surgical outcomes, evaluate the reduction in complication rates, and analyze the decrease in resurgeries post-training. So the study design, it was a retrospective cohort study in which the residents underwent a week-long simulation-based training with theoretical sessions. The outcomes were compared before and after the training, focusing on complication and resurgery rates. We had 8 residents with complication rates more than 2% who were selected for the training. So the retraining program, it included 7-day intensive VRS-based training. We had lectures, video discussions, wet lab sessions, and the training was conducted under experienced senior surgeons. So the residents could practice the key M6 techniques and the steps, following which the residents performed independent cataract surgeries. So this is how the simulator room looks like. You can train more than one trainee at a time. And this is the dashboard in which you can select the particular step that you want to practice. So we'll see some examples. This is the tunnel, side port, keratometry, capsulorhexis, the cortex wash, IOL placement, and restoration of the anterior chamber. So the data was collected. Intraoperative complications were recorded. Resurgeries occurring within 60 days were documented in the cataract surgery database from the EMR system. So in the results, we could see that post and pre-VRS training, the number of surgeries done were almost comparable. The intraoperative complications reduced from 3.6% to 1.2%, which was statistically significant. Some of the intraoperative complications were PC rent with DMD, zonular dialysis, or PC rent with or without vitreous disturbance, dislocation of the nucleus or cortex into the vitreous, and all of them reduced after the simulator training. Coming to the resurgeries, that also reduced from 0.8% to 0.13%, which was also statistically significant. Some of the resurgeries were resuturing or AC deformation, redialing of IOL, removal of the nucleus or cortex from the vitreous, and secondary IOL. The resurgeries also reduced post the VRS training. So basically the training includes a step-by-step surgical tracking for real-time feedback. You can also have a snapshot marking of the errors. That is, you can take a screenshot of your errors and you can discuss it later. There is a performance scoring system according to which you get either satisfied or unsatisfied result, and repeatability. We'll see some examples. So in the first image we can see that the tunnel color is green, the result is satisfactory. The below image we can see there is a reddish color which indicates a premature entry, and the result is unsatisfactory. Similarly, in capsular X's also, in the above image we can see it is complete, the parameters are matched, and you have a satisfactory result. In the below image there is a zonular dialysis, and hence there is unsatisfactory result. So repeatability, what is the main thing actually with the residents? Some of the residents will be having difficulty in particular step, and they can select those steps and they can repeat it n number of times. Again, you can take a screenshot, you can discuss it later with your trainer, and you can judge yourself, and even the trainers can judge according to the performance scoring system. There have also been evidence from other studies which say that there is improved efficiency in performing the steps of the SICS, also enhanced confidence and reduced complication rates after VRS, and it is also more effective than animal models. One of the study also says that you can reduce the OR cost, and you can have long-term savings because it reduces the complications, reduces the resurgeries, and you have better resource utilization. So to summarize the key study findings: significant reduction in intraoperative complications, improved IOL placement proficiency, drastic drop in the resurgeries post the VRS training. So to conclude, the training reduces surgical errors, resurgeries, enhances the skill acquisition, reduces financial burden on hospitals, and it supports the novice surgeons in mastering intraoperative decision making. The limitation of the study was the sample size was small. We need larger studies. No direct cost effectiveness was analyzed, and need for multicentric trials to reconfirm the findings. These are my references. Thank you.
Thank you so much. Definitely, simulator-based training is the need of the hour, and it's so helpful for the patients for a safe surgery. Thank you so much.
Thank you so much.
So we have the next speaker now, Dr. Vijla Janardhan.
Good afternoon, everyone. My topic is biometric accuracy of refractive outcomes using Barrett Universal 2 formula in Holiday schema. It's not moving. Next slide. Okay. The most important factor affecting the refractive outcome of a cataract surgery is the IOL power, and hence the IOL power calculation formula. 1 millimeter variation in axial length can lead to change in the IOL power by 2.5 to 3 diopters. To the best of our knowledge, no study has analyzed the accuracy of Barrett Universal 2 formula in all the ocular geometries described by Holiday schema. So this is the Holiday schema, and the aim is to analyze the accuracy of refractive outcomes by Barrett Universal 2 formula in different ocular geometries by Holiday schema. Retrospective chart review of patients who underwent uneventful cataract surgery by phacoemulsification with in-the-bag intraocular lens implantation was performed in a tertiary eye care hospital over a period of 6 months. So inclusion criteria were like patients with age-related cataracts who underwent uneventful cataract surgery within an age range of 45 to 80 and amenable to optical biometry. The exclusion criteria included intraoperative complications and any prior ocular surgery, presence of any corneal pathology, and trauma or any other comorbid conditions. Ocular biometry was performed using optical biometer OA 2000 by Tomei, and surgeries were performed by a single surgeon with a temporal 2.2 to 2.8 mm clear corneal incision by phacoemulsification, preoperative and postoperative refraction, uncorrected distance visual acuity, corrected distance visual acuity, and the IOL power implanted, predicted refractive error using for Barrett Universal 2 formula were recorded. The sample was divided into 9 categories based on the axial length to short, normal, and long, that is less than 21.6 mm, 21.6 to 25 mm, and more than 25 mm axial length. And based on the Y to weight, it was divided into small, normal, and large. The expected refractive error of the IOL implanted in each subgroup was compared with mean postoperative spherical equivalent. Total number of patients were 663, which included 397 females and 333 right eye within an age range of 45 to 80. The mean axial length was 23.24 and Y2 it was 11.6 and mean refractive spherical equivalent was minus 0.18 and expected refraction minus 0.32. And the normal axial lengths were more prevalent compared to the holiday schema, and eyes with shorter and longer axial lengths were significantly less prevalent in our study, and eyes with normal and small anterior segment geometry were more prevalent, while eyes with large anterior segments were significantly less prevalent compared to holiday schema. The axial length in ascending order is nanophthalmos, hyperopes, microphthalmos, normal, megalophthalmos and myopes. The order is switched for white to white, with microphthalmos smaller than hyperopes and myopes smaller than megalophthalmos, and these are expected differences as the groups are defined according to these parameters. The anterior chamber depth shows statistically significant differences among the subgroups, which increases in proportion to the axial length, except for megalophthalmos, whose anterior chamber depth is smaller than normals. Lens thickness does not show statistically significant differences among the groups, and nanophthalmic eyes have the second thickest lenses, which needs to be taken in the context of this because the ACD and axial length is shorter. The Bland-Altman plots the differences. Bland-Altman plots the differences between a pair against the mean of the pair of measures, and we have plotted the mean of expected and achieved on x-axis versus difference between expected and achieved MRSC on the y-axis. The mean difference is only minus 0.12 diopter, and a constant optimization is not recommended because systematic and proportional differences are nil. Similarly, in axial myopia, a constant optimization was not recommended as the mean difference is only minus 0.04 diopter. Though the slope indicates a positive correlation, a constant optimization was not recommended as systematic and proportional differences were not statistically significant. In axial hyperopia, the mean difference is minus 0.2 diopter. Statistically significant systematic differences are noted, which means that both differ at least by a constant amount, and this can be corrected by adjusting the A constant or lens factor. The outcomes are more myopic than expected, hence we need to alter the A constant by the amount of mean difference. And relative anterior microphthalmos, the mean difference is minus 0.24 diopter. A constant optimization is not recommended due to significant systematic and proportional bias. In positive slope, there is a direct correlation between the means and the difference between the means. In eyes with normal axial length with normal anterior segment geometry, the mean difference is minus 0.14 diopter. A constant optimization is not recommended due to statistically significant systematic and proportional differences. The negative slope indicates that there is an inverse correlation between the means and the difference between the means. So the limitation is it's not adequately powered for the subgroup analysis for all the holiday subtypes and for all the IOL models. And the conclusion, to conclude, the study indicates that holiday subgroups with minimal mean differences and insignificant systematic and proportional bias do not need a constant optimization, that is in nanophthalmos and axial myopes, and groups with only systematic bias and no proportional bias can have better refractive outcomes by a constant optimization as in axial hyperopes, and factors other than a constant optimization need to be considered in subgroups with both systematic and proportional bias to improve the refractive outcomes. Thank you.
Thank you.
Thank you so much.
Hello everyone, I'm Dr. Sonia and I'll be presenting a safety and outcome study on retropupillary iris fixated IOL or IFI implantation under topical anesthesia. I have no disclosures. As we all know, capsular and zonular insufficiencies can be encountered during secondary and primary IOL implantations, and there are a lot of techniques which are being used to implant IOL in such eyes. Studies have reported that none of them can be considered as superior to other, and IFIL is one of the promising candidates, though FDA approval is still lacking for IFIL. So we conducted this study with the aim to analyze the indication, visual outcomes, safety and complications of iris intraocular lens implanted retropupillary. It was a retrospective study where we studied the electronic medical records of the patients. We excluded eyes under 12 years of age, iris abnormalities, active inflammation, pre-existing macular and corneal pathologies, and combined anterior segment surgeries. Out of 209 eyes, 27 were excluded, and we took 182 eyes for the final analysis. The surgeries were done by a single experienced surgeon under topical with intracameral anesthesia. Freedom Iris Claw lens, which is a PMMA IOL manufactured in India, was implanted in all the eyes. The surgery video shows implantation into the retropupillary plane, the haptic being enclaved, and this surgery is being done under topical anesthesia with intracameral lignocaine. We analyzed 182 eyes. There was slight male preponderance. The mean age was 64.6 years. The follow-up was 1 year, 7 months. The main indications were complicated cataract surgery in 106 eyes, and the 76 eyes had undergone implantation for secondary IOL, which included subluxated IOL, aphakia, posterior dislocated IOL, and ACIOL with secondary glaucoma. Around 76% of the patients had BCVA of 0.2 logMAR unit or better at 1 month post of follow-up, and there was mean improvement of 0.47 logMAR unit. Average refractive error was minus 0.26 diopter sphere and minus 1.44 diopter cylinder. We saw no significant change in the intraocular pressure post-operatively. The pre-operative comorbidities which we saw were poor mydriasis, pre-existing phacodonosis, pseudoexfoliation, post-trauma status, macrospherophakia, and coloboma. Intraoperative events, the most common was onial dehiscence, which was noted in 73% of the eyes, and tunnel was sutured in 7.2% of the eyes. The secondary IOL implantation group included subluxated PCIOL, aphakia, posterior dislocated IOL, and ACIOL with secondary glaucoma. Anterior vitrectomy was performed nearly in 90% of the eyes. Rest of the eyes underwent 3-port pars-plana vitrectomy. Immediate post-operative period, we saw most common complications were corneal edema, which occurred in nearly 27% of the eyes, raised intraocular pressure, iritis, hyphema, vitreous in anterior chamber, and vitreous hemorrhage. These complications were more common in the primary IOL implantation group. In the late anterior segment complication, secondary glaucoma, chronic iritis happened in 4.4% of the eyes, followed by disenclavation, iris atrophy, corneal decompensation, and vitreous in anterior chamber. Interestingly, they were more common in the secondary IOL implantation group. 27% of the eyes had developed post-op corneal edema, which was treated with medical management, and 2 of these eyes had to undergo keratoplasty, and this incident was similar with other reported studies. We saw 15% of the eyes who developed immediate post-op iritis, and 4.5% eyes developed late onset iritis. 22% of the eyes had ovalization of the pupil. Disenclavation occurred in 3.3% of the eyes. Posterior segment complications noted were CME, epiretinal membrane, retinal detachment, retinal tear, vitreous hemorrhage, and suprachoroidal hemorrhage. The incidence of that also was more common in the secondary IOL implantation. When compared with other studies, we saw that we have reported the maximum number of eyes implanted in India with Indian manufactured intraocular lens with the longest reported follow-up of 19.8 months. Other complications were comparable to other reported studies. We saw some differences between primary and secondary IOL implantation, but they were not statistically significant. Merits of this study was it reports a large number of eyes, and it emphasizes the fact that it can be done under topical with intracameral anesthesia. We did not take any comparative group. It was a retrospective study, making it a limitation, and we could not study the endothelial density because of lack of data. To conclude, our study reports the largest number of Indian eyes implanted with IFIOL till date. It is effective and safe option to implant IOLs. It is suitable for patients with poor pupil dilatation. It can be successfully performed during the initial cataract surgery. The complication rates being similar between primary and secondary IOL implantation makes it a reliable option for long-term vision restoration. These are my references. Thank you.
So just one question. So this is a retropupillary fixation.
Yes.
So do you do in your center over the iris fixation as well? The iris drop?
Not for the last 10 years.
Right. So I mean, it is definitely a better procedure than.
It is anatomically a better plane to put an IOL.
So cornea is probably more protected.
Yes.
Maybe a comparative data probably.
With the anterior fixation.
Yeah.
तो सर उसमें
could be very helpful. Thank you so much.
देख लीजिएगा वीडियो है शायद
And so the next speaker, Dr. Navneet.
ओके सर
Yes.
Okay.
I'm Dr. Navneet from Arvind Hospital, Coimbatore, no financial interest. My objective is to evaluate efficacy and patient comfort of wig-based anesthesia versus conventional methods in phacoemulsification surgery. It's a prospective randomized control trial, 120 patients with 60 patients in each group. Group A allocated for wig-based anesthesia using cotton wig saturated with 0.5% propagaine for 3 minutes, and group B for standard anesthesia using topical 0.5% propagaine drops for 3 minutes. All patients above 50 years are with no prior ocular surface disease and no prior surgery are included in the study. And patients who are allergic to anesthetic agents and who are inability to provide informed consent are excluded from the study. This is the methodology. The video is not playing. Excuse me. नहीं है. From a sterile bin, a sterile cotton pad is taken onto a tray, and from that a thin, slender and little lengthier cotton wick is made, and this wick is soaked with 0.5% propagating drops. And this soaked wick inserted into superolateral fornix, not the superior fornix. Superior fornix will cause epithelial defect with the blinking. It is inserted into a superolateral fornix, followed by betadine drops installation into the eye. And after this, patient is asked to close the eye for 3 minutes. And over that patient is taken into the table, the wick is removed and the routine sterilization draping is followed as like in any other topical anesthesia. Primary outcomes are measured with patient comfort with visual analog scale, intraoperative pain with numeric rating scale, and secondary outcomes are measured with surgeon satisfaction and anesthesia onset time and postoperative recovery time. And the standard softwares are used, demographics kept same in between both groups. Primary results are patient comfort in wig-based anesthesia is 9.2 compared to topical anesthesia 7.8. Pains rating is almost half of the topical anesthesia in wig-based anesthesia. Group A is 1.2 with group B is 2.4 pain score. Secondary results, anesthesia onset time was faster in group A with 2.5 minutes onset time. Group B it is 3.7 minutes. Surgeon satisfaction is higher in group A with reduced ocular movement. Post-operative recovery and complication rates are comparable in both the groups. Coming to the discussion, we know that topical, we can only put 1 drop into the Coulde sac, remaining drops will get spilled over, whereas with wig-based anesthesia, we can take up to 14 drops with the help of the wig inside the eye. This results in a faster onset of action as the dose is more. And with the eyelid blinking, the topical drug gets washed away, whereas in wig-based anesthesia, it gets released into the tissues, resulting in a longer contact time. In topical anesthesia, the drop will be just above the epithelium, whereas in wig-based anesthesia, it is sandwiched between the upper lid and the sclera, resulting into the deeper penetration of the drug. As we are inserting into the area superolateral fornix, where the squeezing muscles and Bell's phenomena are very active, we reported less squeezing and less Bell's phenomena with wig-based anesthesia. These are the advantages. We can take more amount of drug with faster onset of action. Blinking and eyelid closure results in longer contact time to the tissue. Sandwiching results in deeper penetration with and where the location itself reduces the squeezing and Bell's phenomenon during the surgery. Conclusion, wig-based anesthesia is effective, patient-friendly, improves surgical outcome, and it is very cost-effective, recommended to integration in routine surgery protocols. Strength is, it is a prospective randomized control design. We used validated scales, comprehensive outcome measures. Limitation is in this study we used 120 patients. It's a single center study. Long-term outcome yet to measure. Future directions are we want to take this to large multi-control trials, and long-term safety and efficacy also yet to be assessed, and applicability in other non-cataract procedures also we want to assess. And now our lab is making a pre-soaked and sterilized wick like a fluorescent strip. We can just open and insert into the superolateral fornix. Thank you.
Yeah. So this, I wanted to ask, have you noticed any toxicity of corneal epithelium because using, like you told, 14 times the drops? versus single, have you noticed any toxicity on the cornea?
Yes, sir. It's a longer contact. If it is more than 3 minutes, we observe little corneal change.
But that is important, no?
Yes.
That is an important finding.
Yes, sir. Very important.
Thank you. So the next speaker, Dr. Deshpande, Nitin Deshpande is there. So Dr. Amog, and the next is Dr. Raghav is there. Yeah, kindly be ready with your presentation.
Good morning, everyone. I'm Dr. Amog Jamgi, and my talk today is on the comparison of wet lab skill training in novel mobile-based virtual reality platform versus conventional training. So as surgical residents, when we pass out of college, the most important thing that we notice is there is a huge imbalance between the surgical skills that we acquire in the college and the required proficiency that is required in the hospitals outside. So how can we bridge this gap? There are virtual reality simulators, as I would allude to Dr. Astha, Dr. Ishwa's talks, but they are very expensive. So do we have an inexpensive method to tackle this problem? This will be my talk today. So what are the challenges that we face in ophthalmic surgical training? Basically, there's the high cost of microscope, and the difference between surgery that we do in internship and in ophthalmic residency is that there is an element of stereopsis or microsurgery, which cannot be done without high-end equipment. So there is limited training access even during surgical residency, and there are institutional constraints. So what can we do to overcome this problem? We can have immersive training, like-to-like training, basically like a virtual reality headset, and it has to be comparable to conventional training. So the 4 aspects that we have in virtual reality are the virtual reality environment that we create, the immersiveness, the feedback, and the intent that the method that we have, does it do that? So I have come up with this because I did face these problems during residency. I have named it Vardhan after my son, so it's basically virtual augmented reality, developing an advanced anatomical navigation. So this is the setup. So basically it's the inexpensive virtual reality headset, which costs around 500 rupees, it's off Amazon. And then you connect it to a Android phone. And this can be used as a virtual reality headset. Basically this bypasses the microscope, which in itself will cost you upwards of 1 lakh. So you can give it any webcam feedback, basically USB camera feedback, and this can be connected via USB-C to a normal USB converter, which is again inexpensive. To reduce the working distance, you add a 10 diopter PMMA lens, which again will cost you peanuts. And this is portable and cost effective. It can actually be used for surgical training and to show biomedical or allied professionals what you see during surgery. So the study that I did was a non-randomized experimental study where I involved 20 ophthalmic surgeons, 10 beginners and 10 advanced surgeons. And they did corneal suturing on porcine eyes. And this was the evaluation metrics. We measured surgical time, the precision, and the surgeon's feedback on how they felt the device was. These are the results. As you can see, there is not a lot of difference between conventional microscope and the VR platform that you use. Even there is comparable between the beginners and advanced surgeons. So beginners adapted faster with virtual reality, and advanced surgeons performed similarly in both the scenarios. And then we took the feedback on depth perception. As you can see, around 80% of the people, they agree that that was easy to use. There might be a hitch on getting used to it, which takes around 5 to 10 minutes, and once they get used to the platform, it is very easy. They have good depth perception, and it's very easily accessible and affordable as well. So it's a cost-effective alternative to the virtual reality simulators that we have in the market, like Help Me See or IC. And it is near real experience, as you have actual feedback instead of haptic feedback. And once you add a 10 diopter lens, which you stick it to the front of the web camera, it reduces the working distance, which gives you an actual feel of working in the operating room. You can do this at home as well. So it is a mobile-based VR platform which allows training in diverse settings. So future scope of this would be to add feedback. Basically, you could record somebody operating and then give feedback on if the person is performing well or not. You can record. You can probably hold the camera close to where the surgeon is operating, record virtual reality videos, and you can do amblyopia therapy as well, perimetry. So this is the app face front. This is the front face of the app. And my conclusion is this is a cost-effective and accessible alternative to traditional wet labs. It has potential to reduce the cost of training and revolutionize ophthalmic education and make training more efficient, scalable, and globally accessible. Thank you.
So do you think there is any limitation to it? Any limitation according to you?
Right now, the initial problem that we faced was placing the USB camera, but I would want to now we have overcome that by creating a holder. In the future, we'll probably create a 3D printed model to place the camera, which would make it easier to place the cadaveric eyes and the camera and practice suturing.
So except you, is there any other surgeon
there is no
who has used it and appreciated it?
This was a study on 20 surgeons, basically, and they have appreciated the model.
Look, like the feedback
yes,
you can mention on this.
It was. There's a feedback in it. Basically, this is from 20 surgeons, 10 beginners and 10 seasoned surgeons, and we wanted to see if they actually get the depth perception that we intended to give.
Okay, thank you. Nice.
Thank you so
much. May I start, sir? Good afternoon, everyone. I am Dr. Raghav Malik. I will be presenting my results on comparative study of the Technis Eyehance Toric II with the Alcon Clarion Toric in cataract with astigmatism. Okay, so current day monofocal IOLs have their own limitations, of course. We do get very good vision quality for distance, but for intermediate as well as near, we are lacking. So the patient can get spectacle free for distance, but requires a multifocal lens for or an EDOF lens for intermediate and near. But we know that the trifocal lenses or multifocal lenses come with their own set of demerits, including decreased contrast sensitivity, increased dysphotopsia, and around 7% patients have to go for an IOL exchange if there are, and also some patients also resort to suicidal thoughts in case the dysphotopsias are very high. So there are no known cases of IOL exchanges with monofocal plus IOLs. So this is again a comparison between the EDOFs, monofocal plus lenses and trifocal lenses. We can see dysphotopsia is highest in trifocal lenses, and the patient satisfaction in a monofocal plus lens where you are getting good vision for distance and for intermediate is very, very high. So this is how we as a society have progressed from the 1950s to the current. So if you see this screen, you will see all images where there are only things that have been done for intermediate or distance, nothing for near. And of course there is no screens. From this, we have come to a society where most of our lives are restrained around the 80 centimeter zone. Be it driving, you're driving and looking mostly at Google Maps and not on the road. So that's why this is a study to compare a monofocal plus with a monofocal lens. So the study was a prospective randomized interventional study with 70 eyes, 35 patients underwent cataract surgery with the Technis Eyehance Toric and 30 with the Clarion Toric. The patients had cataract and regular astigmatism, and irregular astigmatism was excluded. So standard phacoemulsification was done for all patients, and standard toric implantation was done. Follow-up was done on day 1, 1 week, 1 month and 3 months. So the purpose was to compare the rotational stability, safety and visual outcomes of the Eyehance Toric with the Clarion Torics. So we use a simple bubble marker, no fancy instrumentation. Patient was made to in a sitting position. The 0 and 180 was marked, and similarly the lens was placed as per the toric sheet. So the observations, the male and female ratio was similar in both groups. So mean pre-op refraction in either group was minus 1.25 and minus 1.2, which was majorly similar. This is the mean post-op refraction. Eyehance was a minus 0.05 and the Clarion was a minus 0.07. Again, both were very, very good for distance. This is again the visual acuity for distance, intermediate and near. So if this is how we compared the IOL stability in the post-op period. The patient was, a clinical photogram was taken, a 0-180 reference line was drawn on the 0-180 mark, and the lens positions were marked with a black dot. So this is the angle which was measured with a protractor, and this was seen as various follow-ups. So So rotational stability. So the mean toric misalignment at 3 months for the IHANS toric was 2.1 degrees and for the acreole toric was 2.9 degrees. So this was insignificant statistically, but there was a slight rotation in the Clarion torics compared to the IHANS. So the rotational stability of both IOLs demonstrated excellent stability. The IHANS had a better stability compared to the Clarion toric. Both groups achieved similar post-op refraction. So this is how you compare for distance, intermediate and near. So the IHANS lens actually has an increasing power from periphery to the center. That's why it is giving a small amount of near add within the central 2 to 3 millimeter zone. That gives a very good vision for distance as well as intermediate, and decreasing the need for near add. So this is how, if you see compare the distance, both the groups had 6 by 6 at 3 months. For intermediate, 6.7 for 6 by 7.5 for the IHANS group and 6 by 9 for the Clarion group, and for near 6, 9 and 6.12. The need for near addition in the IHANS group was about 1.4 diopters of plus power, and for the Clarion toric was 1.8. So that even if you do a micro monovision with the IHANS lenses or with these lenses, you can achieve virtual spectacle independence. So to conclude, both IOLs provided excellent post-op visual outcomes and stability. The IHANS lens as a lens demonstrates superior visual performance requiring less near add than the Clarion toric, and the IHANS toric could be a better choice for patients seeking enhanced near vision without the need of additional correction. Thank you.
So your intermediate and near comparison, was that statistically significant or not?
That is, sir. Yes, sir. Only the rotational instability is insignificant, but the significance does come for the near add as well as the intermediate vision, sir.
But the difference for difference for near was only 1.4 diopter requirement for IHANS and 1.8 for Clarion.
Yes, so that's almost a 0.5 diopter, so that gives us enough depth of focus for the patient to be virtually spectacle free. So for a normal monofocal lens, you would probably have a +2 or a +2.25. If from that we can come to a 1.5, that's a game changer for the patient. So in our practice, we're not even advising a monofocal lens. That's totally cannibalized by a monofocal plus lens. Because there's no loss of vision, no dysphotopsias, the patient just gets an added advantage of that intermediate vision.
Okay.
Thank you, sir.
Good afternoon, everyone. So I am Dr. Saurabh Sharma. Title of my presentation is the Full Moon Capsulorhexis, a case series presenting a novel mid-periphery capsulorhexis technique in intimation cataract. I have no financial interest. So if you see, intimation cataracts are notorious for completing a continuous curvilinear capsulorhexis of anterior lens capsule. Different surgical methods are there to address these difficulties, but all are having the same principle of an initial small controlled CCC to allow for the decompression of the intralenticular pressure, followed by a shape for enlargement of the CCC. The initial small CCC has always been started at the center with the rationale that remaining away from the periphery will reduce the chances of peripheral extension. So our aim and objective is to describe and assess a new surgical technique of achieving a safe and controlled curvilinear capsulorhexis in adult patients with intimation cataract by paradoxically approaching the anterior capsule at the mid-periphery. So it is a case series of 100 adult patients presenting with intimation cataract in a tertiary eye care facility in Kamrup Rural District, Assam from January 2023 to October 2024. Patient having history of serious coexisting ocular diseases were excluded from our study. All surgeries were performed by a right-handed surgeon, that is me. Preoperative acetazolamide or IV mannitol were not used in any of the cases. We have used peribulbar anesthesia in all our cases and dispersive OVD used in all our cases. So here goes one animated surgical video. So side ports are given at 9 o'clock and 3 o'clock positions. Once this is done, the trypan blue is given. The trypan blue is now washed away. So once this is done, OVD is given now. So then what we are making? We are making one small tear at the mid periphery at 6 lockup position. So now the small axis is made. So we are calling it as a full moon because it looks like a full moon in the night sky. So once this is done, then entire lens is now decompressed using bimanual IA. So once this is done, now we are making 2 radial tear and a large flap is made, and finally the adequate sized axis is made. So coming to the results, out of 100 patients, we are having minimum age was 25 with a maximum age of 62 years. Females were 69 and hypertensive were 17 and type 2 diabetes in 22 cases. The initial exercise achieved in 90 cases we get between 1.5 to 2 millimeter diameter, in 10 cases more than 2 millimeter. Final exercise achieved was in 4.5 to 5 millimeter diameter in 44 cases, 5 to 6 millimeter in 55 cases, and 1 case more than 6 millimeter. Fluid coming out after the initial axis, the no fluid in 61 cases, minimal fluid in 26, and excess or milky fluid in 13 cases. Initial exercise, the mean was 1.715 and median 1.75 millimeter. The final exercise, the mean median are almost same, like 5.26 and 5.25 millimeter. We did not get any complications like incomplete initial or final axis, peripheral extension of the axis margin, or Argentine and flag sign. So challenges in performing a CCC in intumescent cataracts are the fragile lenticular capsule, the high intralenticular pressure, and intracapsular pressure gradient shift following opening of the intercapsule at the center. So we postulate that creating an initial small CCC at the mid periphery in intumescent cataract enables the surgeon to approach the intercapsule at its thickest point, thereby the strongest zone, helping in easy aspiration of the cortical fibers close to the equator of the lens, thereby breaking the equatorial barrier, allows for better equalization of anterior and posterior intercapsular pressure compartments. To the best of our knowledge, the full moon capsular axis technique is the first description of a two-stage axis technique approaching the intercapsule at the mid periphery for intumescent cataracts. The technique was found to be safe and viable in creation of a CCC in our series of 100 eyes. Further studies will contribute to confirm the intersurgeon variability in safety and efficiency of the technique. These are some of the references. Thank you for your patient hearing.
So, which viscoelastic do you use?
HPMC, sir. Hydroxypropyl methyl cellulose.
So, do you think use of any hyaluronate or dispersive will help in the technique?
Yes, sir. It helps, but because it's a rural center, we use the HPMC. Okay. Otherwise, it helps. In the literature, it is showing that it helps.
Okay. And do you have seen aspiration of cortex helps sometimes?
Most of the time, because I made it a series, so I made it a serious study, so I use all cases HPMC to disperse those fluid coming out, sir.
Okay. Thank you.
Where exactly in the mid periphery?
Sir,
what is the site?
Yes, sir. Exactly, I'll not say exactly. It is a mid peripheral zone, sir. Yes, sir. And we have not included those cases having 6 millimeter or less than 6 millimeter pupillary dilatation. We have not included those cases, sir.
Okay.
Thank you, sir.
So thank you everybody. It's at the end of the session. We can have one photo session with the speakers, and then we can invite the next session.